So my editor messed up the previous intro for the previous video. I hope that won't happen again, and this is going to be coming out pretty good. I wanted to do a series of videos on my channel, pretty much focusing on electrolyte imbalances. And one of the most important electrolyte imbalances that I want to teach about to begin with is hyperkalemia. I will leave this video in the emergency playlist as well as internal medicine and pediatrics, because I do also talk a little bit about management of hyperkalemia in children, but not in depth. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at hyperkalemia. If you haven't yet subscribed to the channel, hit the subscribe button, hit the bell notification icon so you never miss on such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. So remember that electrolyte imbalances are very important because they have some connotation in the fact that they can actually result in cardiovascular emergencies. They can cause cardiac arrhythmias, they can cause cardiopulmonary arrest. And your patients are going to die if you do not recognize these electrolyte imbalances and if you do not intervene immediately. So to prevent cardiac arrest, you should be able to pick these up clinically. You should be able to know what the interventions are, because these emergencies could affect any individual that is hospitalized. So potassium is one of the very important electrolytes that is there in the body. It is the major cation that you find inside the cells. Remember, outside the cells, which is known as the extracellular space, you have a lot of sodium, very little concentrations of potassium. On the inside of the cells, which is known as the intracellular space, you have a lot of potassium and very little sodium. So potassium accounts for about 98% of it being in the intracellular space and only about 2% of it being found outside the cells. And of this, only 0.4% is found in plasma. So if you actually think about it, the plasma concentration actually just represents a very tiny fraction of the total body potassium of an individual. Remember that the serum potassium measurements have limitations, and like I said, they reflect a very small amount of the total body stores. Most of this potassium is going to be found within the cells, specifically the muscle cells. So this means that total body potassium is roughly going to be proportional to the lean body mass. And remember also that cells are bags of potassium. So anything that is disrupting the cell and killing off the cells means that you're releasing all this potassium into the bloodstream. A healthy adult requires about 50 milliequivalents per kg of potassium in their body. So suppose we had a 70 kg old man, it means that they would require 3,500 milliequivalents or millimoles of potassium, or they would have that in their body rather. So it means that if you have a drop by 1 millimole or 1 milliequivalent per liter, this is going to be translating to a loss of about 200 to 400 milliequivalents of the total body potassium. So roughly you need to replace this deficit. So if a patient, for example, has a potassium concentration of 2.5, it means they roughly are in about minus 300 milliequivalent negative. So it means you need roughly about 7 boluses of the 40 milliequivalents of potassium to make this up. But of course, this shouldn't be done instantly. It's usually replaced gradually. I'll talk about the replacement of potassium when we talk about hypokalemia. My focus here is with hyperkalemia. So patients that have a stable potassium concentration of 3 millimoles typically are going to have a significant potassium deficit. Remember that potassium is going to be important in the body because it's responsible for different intracellular osmolalities as well as determining the cell membrane potential. Very important because its gradients are strictly maintained across the cell membrane, and this is very important for cell nerve conduction. It's also very important for the myocardium, functioning of the myocardium. And the potassium is going to be actively pumped into the cells by the sodium-potassium ATPase, which pumps out 3 sodium ions in exchange for 2 potassium ions. Some of this potassium is freely filtered out in the glomerulus, and it's going to be absorbed in the proximal as well as the ascending tubules of the kidneys, and some of it is going to be secreted in the distal tubules of the sodium-potassium channels. Small alterations in the potassium concentration are going to cause significant clinical manifestations. So they may cause weakness, they may cause cardiac arrhythmias, and generally, clinical features of hypo and hyperkalemia may overlap to some extent. Now remember that the Normal potassium concentration is about 3.5 to 5.5. So if potassium can shift into the cells, it can shift out of the cells, and this can largely affect the serum concentration of potassium. So if you get an increase in the serum concentration of potassium, we call that as hyperkalemia, which is what I'm going to be talking about in this lecture. And if you get a decrease in the serum potassium concentration, we call that as hypokalemia, which I'll talk about in a subsequent lecture. Daily, you need a potassium intake of about 40 to 150 milliequivalents. That's roughly about 40 to 150 millimoles per day. And remember that in a steady state, the fecal losses are usually close to 10% intake. The remaining 90% is going to be excreted in the urine. So any alterations that are happening in renal potassium excretion are going to greatly affect the potassium balance in the body. So when the potassium intake is greater than 150 millimoles per day, about 50% of this excess is going to actually show up in the urine over the next several hours. So potassium can shift in and out of cells via three important factors. So it's going to be influenced by three important things. Acid-base balance, it's going to be influenced by beta-adrenergic activity, it's going to be influenced by insulin concentrations. What do I mean by acid-base balance? The predominant thing that's going to be here is, remember that the body maintains homeostasis. And whenever there is a change in the pH, this is going to greatly also affect the potassium concentration. It's more important when you get changes in bicarbonate concentrations than when you actually see changes only in the pH without the bicarbonate changing. But the changes in the pH also do affect the levels of the potassium. Remember that some cells have the hydrogen potassium ATPase pump, which tends to react in terms of acidosis. So for example, if you have an acute metabolic acidosis, these cells are trying to buffer out the pH that is going to be dropping. So what's going to happen is that the hydrogen ions are going to be pumped into the cells in exchange for potassium ions, which are pumped out of the cells, and this will cause hyperkalemia. In someone who has acute metabolic alkalosis, the opposite is happening. Hydrogen ions are being pumped out of the cell, while as the potassium ions are being taken into the cells to actually maintain that pH. Then with the bicarbonate changes, this is actually much more important than the changes in the pH, like I told you. Often when we see acidosis that is as a result of mineral acids, that's a non-anion gap hyperchloremic acidosis. This is most commonly associated with elevations in serum potassium. If we see metabolic acidosis, which is due to accumulation of organic acids, when there's an increase in the anion gap, this is often not really associated with hyperkalemia. This is a very high yield point to actually learn. So it means that in patients that actually do have DKA, they have the hyperkalemia because they're having insulin deficiency, not generally because of the acidosis itself, because they have a metabolic acidosis because of accumulation of these organic acids. Remember that acute respiratory acidosis and alkalosis are going to affect serum potassium concentrations to a much lesser extent than we see with metabolic acidosis and metabolic alkalosis. But regardless, the serum potassium concentrations should always be interpreted in the context of the serum pH and in the context of the bicarbonate concentration. Remember that beta-adrenergic activity can also affect how potassium moves across cells. You have some beta-2 agonists which move potassium into the cell. So drugs like albuterol, drugs like salbutamol, we can actually utilize some of these drugs in the management of hyperkalemia. Beta blockers and alpha-adrenergic agonists are going to be promoting potassium moving out of the cells and are going to be promoting hyperkalemia. In terms of insulin concentration, remember insulin is going to help drive potassium into the cells. How does this work? Remember, when insulin is present, it binds to its receptor. This is going to cause the expression of those glucose transporters. Uptake of glucose is going to increase, and that glucose ultimately will be metabolized and release ATP. Remember, ATP is going to be used to drive the sodium-potassium ATPase pump, which is largely taking in 2 potassium ions, pumping out 3 sodium ions, and this is decreasing the potassium concentration in the bloodstream. Low concentrations of insulin that we see in DKA are actually what's going to be causing the potassium to be trapped on the outside and even some of the potassium to move outside the cells, and this is going to be raising the potassium concentration in the bloodstream, though this in the background, the total body potassium will be deficient. So in essence, remember that the serum concentration only represents a fraction of the total body potassium, but in essence, these patients still have a potassium deficiency, which is why even when we treat them with insulin, they are going to require potassium at a certain point. Now let's go into details and talking about hyperkalemia. Remember, this is a serum concentration greater than 5.5. Remember that the normal concentration is going to be regulated through 3.5 to 5.5. Hyperkalemia is the most common electrolyte disturbance that's going to be associated with cardiac arrest. So it may cause diastolic arrest, it may cause ventricular fibrillation. Some of the causes could be divided into the following groups. You could have someone who's having increase in intake of potassium. It could be through oral or even IV potassium supplements. You have a patient that was hypokalemic. You over enthusiastically give them potassium. It may raise the potassium concentrations. And just for a side note, one of the drugs that we actually use to kill patients, and rather to kill people via the lethal injection, is actually potassium chloride, which is actually injected into this person's bloodstream as a bolus and can actually stop the heart. You may also have massive blood transfusions. Remember, cells are bags of potassium, or if you're transfused with blood that has been stored for a long time, some of these cells have been hemolyzed, potassium concentration in those blood are high. High doses of penicillins that can increase potassium in the bloodstream. Then it could be because you are not excreting potassium. Remember, the bulk majority of potassium is excreted from the kidneys. So patients that have acute or chronic renal failure, patients taking certain drugs like potassium-sparing diuretics, drugs like ACE inhibitors, drugs like aldosterone antagonists, which are pretty much going to be causing the reabsorption of sodium and the loss of potassium in terms of are going to be affecting this in terms of the spironolactone. Then you may also have some NSAIDs and even heparin itself. You may have Addison's disease and hypoaldosteronism, where they don't have aldosterone. And remember that aldosterone is required for the reabsorption of sodium and the loss of potassium. If this is not happening, it means that potassium will be reabsorbed, sodium is lost. Same thing is happening with the spironolactone. It could be in the background of someone having increase in production or cell injury. Remember, I told you cells are bags of potassium. So it could be in the background of burns, ischemia, hemolysis, crush injuries, incompatible blood transfusions, tumor lysis syndrome, rhabdomyolysis, or even intense activity. Anything that can be causing transcellular shifts of potassium, like acidosis, I've talked about, especially metabolic acidosis, hyperglycemia, digoxin poisoning. It's very important to remember that in terms of the digoxin poisoning, when you get patients that are on digoxin and have had poisoning, you give the antidote, the digibind, as opposed to giving them calcium to stabilize the myocardium. Then you may also have succinylcholine and beta blockers. Insulin deficiency, I've already talked about that. You may sometimes have a pseudo type of hyperkalemia. It's supposed to be hyperkalemia, not hypokalemia. A pseudo type of hyperkalemia, even a factitious or spurious type of hyperkalemia. This could be because the sample has been hemolyzed. This is a very, very major cause of hyperkalemia in most patients. So it could be an incorrect vena puncture technique. Maybe you are putting the tourniquet for too long. Maybe it's applied too tight. Maybe the person is clenching their fist too tight when you're drawing the venous blood. This is going to all cause hyperkalemia. Even when you're putting the sample in the container, maybe you haven't removed the needle and you're pushing it very quickly through the needle. The cells are being hemolyzed as they're passing through that needle, the small opening into your vacutainer. It could be due to thrombocytosis, so massive leukocytosis. Remember, platelets are going to release the potassium during the process of clotting. Or it could be someone with cold agglutinins. Remember that when you're actually using succinylcholine for rapid sequence induction in those patients that have suspected hyperkalemia, or in patients with neurologic conditions like GBS, muscular dystrophy, an old stroke, burns, crush injuries, or spinal injuries, remember you should not use this drug because it's going to predispose them to large increases in the serum potassium. How do we grade hyperkalemia? It could be mild, between 5.5 to 6, moderate, between 6.1 to 6.9, and severe if it's greater than 7 millimoles. Clinical features: you may have palpitations, muscle cramps, muscle weakness, paresthesia, ascending paralysis, loss of deep tendon reflexes, hypotonia, focal neurologic deficits, hypotension, hypoventilation, respiratory failure, and cardiac arrest. In some individuals that have hyperkalemic familial periodic paralysis, they may actually have this weakness that frequently develops during these certain attacks, and then it will progress to frank paralysis. In some patients, they may actually even be asymptomatic. Some ECG changes that you expect to see from the most common to actually the changes that you see when the samples are, or rather the values of potassium are not so high, to when the values of potassium are quite high. You may have symmetrically peaked T waves, you may have small or absent P waves, You may have widening of the QRS complex. You may have a sign pattern, that's a sinusoidal QRS complex pattern. You may have AV dissociation or even a ventricular tachycardia or ventricular fibrillation. Remember, for those that have a potassium concentration between 6.5 to 7.5, you're going to see prolonged PR interval. At peaked T waves, you may see a shortened QR interval. For those between 7.5 to 8, you may get flattening of the P waves, QRS complex widening, and then those between 10 to 12, you may get a QRS complex degrading into a sinusoidal pattern. This is what it looks like. So here, you have a person that has a potassium concentration of 3.6, no more ECG. Then here, in someone who has 6.8, as you can see, these T waves are tented and they are tall. You may sometimes even see that the QRS complex is beginning to widen, because remember, it must be at least fitting in one box. You're seeing that the QRS complex is beginning to widen, and then eventually you're even getting this sinusoidal pattern, this sign pattern that we're going to see. The P waves are also going to begin to flatten out whenever you see that hyperkalemia is actually progressing. As you can see, the QRS complex is widening. You may sometimes get some ST segment elevation or ST segment depression as this advances. And one important thing to remember is that even though we do emphasize on these ECG changes, the ECG actually has shown poor sensitivity to hyperkalemia changes, and actually only 32% of ECGs in patients with known hyperkalemia actually do have the peaked T waves, and only 52% exhibit the other changes that are associated with hyperkalemia. How do we approach our patients? So remember that anyone with a potassium concentration greater than 6.5, unless if it is a pseudo type of hyperkalemia or it's an incorrect result, you need to treat these patients urgently. You need to gain your IV access, you attach them on an ECG machine, get an urgent ECG. So if your ECG is showing that they have some changes of hyperkalemia, you start your treatment immediately. If there are no ECG changes, then you make sure that you exclude any pseudo hyperkalemia. So you recheck the venous sample, you recollect the sample with the right technique to avoid hemolysis, and you should avoid any heparinized samples. Order for other investigations like a serum electrolyte panel, which is going to include magnesium levels, a serum blood urea nitrogenous wastes, your creatinine, as well as your glucose, which you can also measure at the bedside. So you're going to look for changes on the ECG that are usually progressive and are going to be pointing towards hyperkalemia. So you may see tall, peaked, or tented T waves. You may see prolonged PR interval with flattening of the P wave. You may see ST segment depression. You may see QRS complex widening. You may see absent P waves. You may see a sinusoidal pattern. You may see ventricular tachycardia. Sometimes it may go into a cardiac arrest from a ventricular fibrillation. Sometimes it may have a pulseless electrical activity or an asystole. I did talk about the management of cardiac arrest in another video. Consider hyperkalemia in any patient that has an arrhythmia or any patient that has cardiac arrest. And without any ECG findings, the treatment is just going to be limited to you actually decreasing the intake of potassium and giving them potassium excreting drugs. I'll talk about these drugs very shortly. If the ECG findings are of this hyperkalemia, you want to protect the heart. So you give them agents that are going to protect the heart, such as calcium. You give them agents that are going to quickly drive potassium into the cells. That's drugs like insulin and glucose. Then, of course, you give them something for a definitive management to get rid of that potassium, something like dialysis. And then often you're going to give these patients calcium if you notice that this QRS complex widening. Sodium bicarbonate is used, but it's only effective in patients that are acidotic. For those that are non-acidotic, it may not actually even have benefits. There may be more risks than benefits with its use. So if the patient has a normal ECG, normal potassium levels, then hyperkalemia is unlikely. It's probably something else. If the patient has ECG changes showing hyperkalemia, for example, peaked T waves and their potassium concentration is about 5.5, give them something to stabilize their heart. Give them an IV calcium gluconate or a calcium chloride. Remember, calcium chloride is going to be given via central line because it may cause some nasty skin reactions. And remember that calcium is not going to be lowering the potassium levels. It's just going to be antagonizing the effects of hyperkalemia. It won't lower the potassium concentration. Then you want to lower the potassium concentrations temporarily. So you want to give them insulin with dextrose. You can nebulize with your beta agonists like albuterol. You may consider giving them sodium bicarb. Then you also want to lower their total body potassium. This may take some time, like with loop diuretics or even potassium binding resins like kayexalate. If the ECG is normal but their potassium is above 5.5, you want to gradually lower the potassium. So giving them your loop diuretics and or our Kayexalate. So here's an image of ECG findings of a patient that has severe hyperkalemia. As you can see, they have this widening of the Kearns complex. They have these peaked T waves, especially in these unipolar chest leads. Then this patient was then given some treatment with the hyperkalemia treatment, and this was their ECG after they received the treatment. As you can see, the Kearns complexes have narrowed. The T waves are no longer as peaked as they were in the previous slide. And even the rhythm seems to appear normal. So how do we manage patients with hyperkalemia? So you want to give them high flow oxygen via our face mask. You want to stop any exogenous sources of potassium if they're taking any potassium. And if the patient has severe hyperkalemia with a potassium greater than 6.5 and they have this life-threatening ECG changes, the first thing that you must always do is protect the heart. So give them 10% of calcium gluconate or calcium chloride. If it's calcium gluconate, you're giving 10 mils. If it's calcium chloride, you're giving 5 mils over 2 to 5 minutes. And then you should repeat until the ECG and the cardiac output actually normalize. And like I told you, calcium chloride or calcium gluconate are not going to lower the potassium levels. They're just simply going to antagonize the effects of hyperkalemia on the myocardium. They stabilize the myocardial membrane. So they're going to reduce the risk of ventricular fibrillation. But remember that hypercalcemia may potentially actually exacerbate the toxicities of digoxin. So like I told you, don't give those patients that have digoxin toxicity, give them the antidote to digoxin toxicity as opposed to giving them the calcium. But if you're giving them the calcium, give the infusion very slowly over 30 minutes. The onset of action or the onset of protection is within minutes, so about 1 to 3 minutes. You also want to shift the potassium into the cells and eliminate it from the body. Of course, I'll discuss this in the subsequent slides. Then in terms of those that have moderate hyperkalemia, 6 to 6.5, again, you're going to protect the myocardium. You give them that calcium gluconate or your calcium carbonate. You want to shift the potassium intracellularly. So you want to give them 50% dextrose with 50 mils or rather 50 mils of 50% dextrose, and then you're going to be giving them 10 international units of soluble insulin over 20 minutes. Remember, number one here, you want to give the dextrose first, then followed by the insulin. You shouldn't give the insulin, then the dextrose. So if they have hyperglycemia and their blood sugar is greater than 12, give the insulin without actually giving the dextrose. So remember that this is going to help lower the concentration of potassium by driving potassium into the cells, and it actually lowers the potassium levels by about 1 millimole per liter within an hour. The onset of action is about 15 minutes, and it can take maximum effect within 1 hour. Then you should avoid giving dextrose 50% rapidly, because this can also cause a paradoxical rise in the intracellular potassium because of the hypertonicity of the solution. You may consider giving them salbutamol nebulization, 5 to 10 milligrams. You can actually repeat this, and the action onset is about 15 minutes, and this is going to lower the potassium in most patients in about 30 minutes. The sodium bicarbonate is given often to patients that have an acidosis. So about 8.4% of sodium bicarb, 25 to 50 mils. IV over 5 minutes, that's about 1 ampule. And this should be given if there is no risk of fluid overload, and because this is going to be consisting of 50 millimoles of sodium. On its own, it's not so effective, but if you combine it with other agents like salbutamol and even dextrose with insulin, then even in a patient that have metabolic acidosis, they may actually benefit from this treatment. For those that have mild hyperkalemia between 5.5 to 6, you just want to remove the potassium from the body. So you may consider furosemide, 40 to 80 milligrams. Remember, this has to be given in patients that are passing urine. Don't give it in patients that are anuric. Then potassium exchanging resins like calcium resonium, even Kayexalate, can be given orally, 30 grams orally or by enema, and the onset is about 1 to 3 hours after administration. This is like cement, so it can actually cause constipation. Then you want to treat the underlying cause and treat any hypovolemia that is happening in any of these patients that have severe, moderate, or mild hyperkalemia. And remember, you want to organize for urgent hemodialysis or peritoneal dialysis as needed, especially for those patients with renal failure. And when you're treating hyperkalemia, initiate your treatment with your calcium, your insulin with glucose, Kayexalate, and prepare them for dialysis. You should consider sodium bicarb as well as the salbutamol and albuterol as adjuncts. They're not really mainstay treatments. and ultimately it's only kyoxalate, dialysis, and diuretics that are actually going to be offering definitive treatment, because they're going to be removing this potassium from the body. These other things like insulin with glucose are just shifting potassium into the cells. This potassium can also shift back into the extracellular fluid and can still cause the problems if it's not addressed. How do we manage hyperkalemia in those patients that now have had cardiac arrest? I've already talked about cardiac arrest. I'll leave it tagged at the end of this video so that you can watch the video. So if a patient has arrested because of hyperkalemia, you follow your advanced life support guidelines and one of the following things. So you protect the heart, 10 mils of 10% calcium chloride or calcium gluconate, IV by a rapid bolus of injection. Consider giving them 10 international units of short-acting insulin with 100 mils of 50% dextrose. And then if they have severe acidosis, consider giving them 50 mils of 8.4% sodium bicarb rapidly as an IV infusion. Then you may consider hemodialysis for those that have cardiac arrest that is induced by hyperkalemia and are not responding to medical treatment. In terms of management of hyperkalemia in children, remember that children may actually present with hyperkalemia greater than 7, especially those with advanced renal failure. So you want to actually prepare them for emergency dialysis. In the meanwhile, call for help from your seniors. Stabilize the myocardium with our calcium gluconate, 0.5 mils per kg, 10% calcium gluconate over 5 minutes. Then if they have these ECG changes of widening of the Cura's complex or the tau T waves, give them sodium bicarb, 1 millimole per kg IV, and commence an IV infusion of glucose, 0.5 grams per kg per hour, with an insulin infusion of 0.05 units per kg per hour. Consider nebulizing them with salbutamol, 2.5 milligrams if they're less than 3 years, 5 milligrams if they're between 5 to 7 years, and 10 milligrams if they are greater than 7 years. Consider calcium resonium, that's 1 gram per kg orally or even rectally. Remember that nebulized salbutamol, sodium bicarb, glucose, and insulin are all temporal measures. They're just going to be shifting insulin into the cells. The definitive thing that you want is, of course, to get rid of that excess potassium, of which dialysis may still be required in these children. Here's a high-yield table that summarizes everything I've been talking about in terms of the intervention, the category, the usual dose, the onset of action, the duration of action, and the important details for you to remember. If there is a table that I want you to actually take a screenshot of, pause the video, get a screenshot of this, and this is what I want you to keep in your mind. Remember that kyoxalate should be avoided in intestinal necrosis in patients that are post-operative with post-operative ileus, because it may actually cause intestinal necrosis rather, and it may worsen patients that have pulmonary edema. It may worsen because of the fluid overload, and the efficacy of how much potassium it actually gets rid of the body is actually quite poor for most of the research. Calcium chloride has 3 times more calcium ions than calcium gluconate, and the onset is within minutes and lasts up to 30 minutes. Then calcium chloride, ideally, like I said, give it through a central line. You don't want to give it via a peripheral line because it may cause accidental skin injuries. Remember the ABCDs of hyperkalemia treatment, and remember a combination of these is better than giving single therapy. A for albuterol or salbutamol, B for bicarb, C for calcium, D for dextrose with insulin, dialysis, and diuretics. Remember that hemodialysis is the most rapid and effective way of lowering potassium concentrations. Now, what's our disposition as we end this lecture? Remember that when you see patients with ECG abnormalities or any clinical manifestations of hyperkalemia, you want to keep this patient in an ICU, and you want to continuously monitor their cardiac activity. You want to connect them to a continuous ECG monitor. You want to discharge patients that have mild elevations of potassium after you have treated them, if they don't have any clinical features, if they don't have any ECG abnormalities, and provided that you have found an underlying cause or underlying risk factors, and those have been corrected and those have been taken care of. The patient should then be followed up for further evaluation within about 48 to 72 hours. I really hope you enjoyed this video on hyperkalemia. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.